Okay, so today we'll be talking about oxygen transport, and this is going to be also covered in Chapter 6 in Desjardins. So if you need a book resource to help supplement this, I would highly recommend taking a look at Chapter 6 in Desjardins. Alright, so again, a lot of this should be review, but we're going over it again just to kind of make sure it's solidified in your brain. Oxygen transport, we're looking at the ability of the blood and the heart to carry oxygen throughout the body. And as you know, it is carried in two different ways. It is dissolved in the plasma, and it is also bound in hemoglobin. Okay, so talking about the oxygen dissolved in plasma or in the blood, that again is the smallest part of how much. That's where we take our PaO2 and then we multiply it by that 0.003, okay, and then that gives us a volume percent. So this the atmospheric pressure allows oxygen to diffuse from the alveoli into the pulmonary capillaries, where it dissolves in the plasma. So the PaO2, the partial pressure of oxygen, is only a small part in how oxygen is transported. Another note that I want to say, so when you're reviewing these PowerPoints, so I'm trying to have this organized, and I mentioned it on the announcement. So as you look, I'm trying to get this organized into days. So this is day 2, all right? The first PowerPoint that's going to be listed, if you download it and you have PowerPoint, you should be able to see the little notes that are underneath the main screen. Okay, so those are some of the extra things that I'm saying that aren't necessarily on the main screen or the big slide. Okay, so unfortunately you're not able to view that here on the YouTube video, but I have that as the first one that's listed is like the original one that I would normally do in the class, and it has those speaker notes that are underneath there. So I'm hoping you have the ability to view those along with listening. So if you have two different devices, or if you print them, or however you do it when you're going through these PowerPoints. Alright, so again, so this is the smallest amount, and it's basically representing the amount of oxygen in mils, that is in 100 mils. That gives us our volume percent. So when we take that 0.003 mils of oxygen dissolves in basically in 100 mils of blood per 1 milligram of PO2. Okay, so it's the amount of oxygen in mils that is in 100 mils of blood. And then when we look at the oxygen bound to the hemoglobin, so that's our oxyhemoglobin, and our normal values there that you should be familiar with. So the oxygen is bound to the hemoglobin by a chemical reaction. A red blood cell contains 4 heme groups and 4 amino acid chains. So 4 hemes to 1 globin, G-L-O-B-I-N, can carry 4 oxygen molecules. When all 4 are bound, then it is 100% saturated. When only 3 are bound, then it is said to be 75% saturated. Each red blood cell contains about 280 million hemoglobins. Okay, so each red blood cell contains approximately 280 million hemoglobins. So in a patient then that is anemic, that has a low hemoglobin, obviously is going to have less capability of carrying oxygen. Alright, so the oxygen then bound to the hemoglobin, so each gram percent of hemoglobin is capable then of carrying 1.34 mils of oxygen. And so that's why we take the hemoglobin number times your SAT, okay, your SaO2, which should be in decimal format. So for example, if it's 90%, you're going to use 0.9 when you do your math, and then times that by the 1.34. Okay, and then as we go further down here on the screen, when we're looking at the total oxygen content, the CaO2, we're basically taking both of those numbers together. So we are looking at the PaO2 times, again, the part that's dissolved in the plasma, times the 0.003, and then we're adding that to the part that's bound to the hemoglobin. So those together then are your CaO2, your oxygen content in your blood, which is represented in volume percent. And volume percent is grams per 100 mils. So volume percent is grams per 100 mils. So oxygen content in the blood then is your CaO2. This is the amount of oxygen that is actually transported then to the tissues. Okay, and our normal value then is about 15 to 20%. Then your CbO2 is the oxygen content in mixed venous blood. Okay, the way you can get an estimate calculation of this, but the only true mixed venous blood can only be really obtained, the true value really could only be obtained by a Swan-Ganz or a pulmonary artery catheter. So obviously that would be an invasive way of doing it. So we look at a little mini case study here. We have a 30-year-old female that comes into the ED complaining of shortness of breath. Her heart rate's 140, her respirators are 36, blood pressure 155/90. Her CBC shows that her hemoglobin is 6 grams percent. ABG, however, shows that she's 88 for her PaO2 and her stat is 90%. However, she is still feeling short of breath. Even those other numbers can be misleading. Okay, so if you calculate her CaO2, I'll give you a few minutes to do that. So I'm going to actually put you on pause so that you can do that. I'll walk you through it here a little bit. So remember, you're going to take your 6, okay, you're going to multiply that by 1.34 times 0.9, okay, so that's the part bound to hemoglobin. Okay, so you're going to do that part by itself. Then you're going to add that to 88, because that's your PaO2, times 0.003. Okay, so if you had a moment to get your math done, you should have came up with a number of 7.5, should be your CaO2. Is that a normal number? No, because we just said that our CaO2 should be about 15 to 20 volume percent, and we got 7.5. So this is a low number. Okay, and one of the first organs that can fail, that's going to take a hit from this low number, is your kidneys. So what does this woman need? I hope you are saying she needs blood, okay, because her hemoglobin is 6. All right, visiting our friend, the oxygen dissociation curve. We all love that. Alright, so oxygen dissociation curve again represents the percentage of hemoglobin that is chemically bound to oxygen at each PaO2. Okay, so as we look at this, we have a steep increase in the beginning, and that is representing that the hemoglobin has a high affinity for oxygen. Because initially the hemoglobin doesn't have much oxygen bound to it to start with. So then as the PaO2 increases, the affinity or binding of oxygen levels out, so then less oxygen can jump onto the hemoglobin. That's that cooperativity, oxygen binding to hemoglobin. So P50, when we talk about P50, that is where the hemoglobin is 50% saturated with oxygen. now we're going to look at, on the next couple slides here, on the different shifts that we see. And you should hopefully have these in your head. Okay. So we have a shift, things that would cause it to shift to the right. Okay, so when we think of shift to the right, we should think about a decrease in pH, which would be increased PCO2, increased temperature, increased 2,3-DPG. This is where the tissues are going to need more oxygen. Okay, so your metabolism is up. Okay, so it's going to require, your tissues are requiring more oxygen. And because your metabolism is up, you have an increased temperature, fever, for example, you're also going to be producing more CO2, which kind of goes in line with that decreased pH. So I remember telling you guys, I think before, about the little acronym of CADET, C-A-D-E-T, face right, a cadet face right, like as in a salute. C standing for the CO2, A for the acidosis, D for the DPG, E for exercise, and T for temperature going up. Okay, so that's where we have this lower affinity for lower oxygen affinity because we need to give up more to the tissues. Okay, so the means that the P50 then is shifting to the right. This means that it takes more pressure or more PO2 to get the hemoglobin 50% bound to the oxygen. So the oxygen delivery, sorry, dog barking. So the oxygen delivery may be lower than indicated by the PaO2 when it's shifting to the right. So again, the pH is dropped. When the pH decreases, more oxygen then is unloaded at the tissues, meaning less oxygen stays bound to the hemoglobin. Increased temperature, like exercise, more oxygen needs to be unloaded to the tissues to keep them working. And then the increased PCO2 results from the decreased pH. And then your increased 2,3-DPG is the metabolic component that is formed during anaerobic glycolysis. So because the body is working at an anaerobic level, for example like sprinting, more oxygen needs to be unloaded at the tissue, which means less will be held in the hemoglobin. So you need more pressure to get more oxygen to bind. And I also have in my notes here to estimating your PaO2. Don't forget that that one rule of, and I know I wrote this on the board. I'm trying to think. I think it was in Res 286 at the beginning of mechanical ventilation. The 40, 50, 60, 70, 80, 90 rule. So if your PaO2 is in the 40s, your SAT's probably going to be in the 70s. If your PaO2 is in the 50s, your SAT's going to be in your 80s. And your PaO2 is 60, your SAT about 90. Okay, so this is assuming a normal pH and your CO2 and hemoglobin values. But that's just kind of that estimate PaO2, that 40, 50, 60, 70, 80, 90 rule. Okay, now things that shift the oxygen hemoglobin association curve to the left is going to be your increase in your pH, so more alkalotic, which you'd see with a decreased PCO2, decreased temperature, decreased 2,3-DPG, fetal hemoglobin, and carboxyhemoglobin. Okay. So this is where you're going to have a greater affinity to the hemoglobin. Okay, so the lungs kind of have it more. Okay, you're less at the tissues. So it takes less pressure to bind hemoglobin with oxygen, but it takes a larger pressure change to actually unload the oxygen from the hemoglobin, because partly because there is less need of oxygen at the tissues. So we have an increased affinity of hemoglobin for oxygen, which enhances its uptake from the alveoli. So if we have an increased pH, So we see then a less need for oxygen at the tissues, and the hemoglobin hangs on to more oxygen, so it's not going to give it up. Decreased temperature, again, less need for oxygen at the tissues, same with decreased 2,3-DPG. Fetal hemoglobin is a mechanism that makes it easier to transfer maternal blood to fetal blood. Think of it as the fetus doesn't need to do much because the mother gives the baby most of what it needs, so the oxygen needs are lower. So there's less need again to deliver oxygen to the tissues. And then your carboxyhemoglobin has 210 times more affinity than oxygen, carboxyhemoglobin does. So the little oxygen that combined with hemoglobin kind of gets mixed in with this carbon monoxide and has a difficult time in actually dropping it off at the tissues. Another video for you to review if you care to, and I know you've seen it before because I know I've showed it to you, is the Haldane effect video. If you go on YouTube and type in Haldane effect, Bohr effect versus Haldane from Khan Academy, feel free to watch that again. I think he does a pretty good job of explaining all this kind of too, how the association and the affinity of the hemoglobin. And it's about a 13-minute long video. Alright, some other things that we look at on oxygen transport is the list here of oxygen delivery, total oxygen delivery, your DO2. And the next slides here are going to kind of break each of these down. So these are things that we look at to determine adequate oxygenation. So total oxygen delivery, your A to V, content difference, your oxygen consumption, your oxygen extraction ratio, your mixed venous oxygen sat, and then your pulmonary shunting. Alright, so things that we need to think about and look at, questions that we need to ask ourselves are, is the oxygen delivered adequate for the patient's needs? Is the cardiac output adequate for the oxygen consumption? Is oxygen consumption adequate for the oxygen demand? And is the patient's hypoxemia due to a pulmonary problem, or is it more of a low flow state? Okay, so these are questions that we have to ask ourselves. Okay, so when we look at oxygen delivery, we can look at it as the supply. Okay, so DO2, where we look at how much supply is actually available to the tissues. And this is going to be dependent on the body's ability to oxygenate the blood, so how well our lungs are functioning, the actual hemoglobin concentration, so how much is available there, and our cardiac output. Are we able to get it out to where it needs to be? So we look at oxygen delivery, and this is one of our equations that we need to remember. So we are looking at our DO2 then is equal to QT, meaning cardiac output. Okay, so remember cardiac output is also QT. And then we are looking at what is dissolved in the plasma to get our CaO2 plus what is bound to the hemoglobin. So we have to do that calculation to get our CaO2. And then we're timesing it by 10 because that is what is converting it to milliliters then. So if your patient's cardiac output is 5 liters per minute, because that's, we're converting them from liters to mils, and a CaO2 is 20 volume percent, then you need to calculate the DO2. So if you're doing your math, you should be taking 5, multiply, 5 being your cardiac output, multiplied in parentheses 20 times 10. So you have 200, and then you take that, multiply it by your 5, so that should give you 1,000 mils of oxygen per minute. Okay, so that is a normal value. The normal DO2 is 1,000 mils of oxygen per minute, because we're working with normal values to begin with. All right, so think of things that might cause a DO2 to be decreased. Some things that would cause a DO2 to be decreased. Well, if I just kind of look at what makes up my equation, one thing that sticks out to me right away is cardiac output. Okay, and other things, part of the CaO2 is your hemoglobin. Okay, so things that would make your DO2 be decreased would be a decreased hemoglobin, your decreased blood oxygenation, decreased cardiac output will actually often increase then as it tries to compensate for decreased oxygen delivery. So that compensatory mechanism starts to kick in. So if your body is low, has a low DO2, you actually might end up seeing an increase in your CO2, or I mean your CO rather, your cardiac output, as a way of a compensatory mechanism. And you'll also see an increase in your heart rate and an increase in your blood pressure. But if the body senses that's low to begin with, it's going to quickly compensate if it's able to. All right, so now we look at the A to V difference. Okay, so we're looking at the difference between the CaO2 and the CbO2. So we look at what the body is actually using. Okay, so what the body is using. So when we do the calculations on this, if we have a normal of about 20% in the CaO2 and a normal value of about 15% in the CbO2, the difference between those two is 5 volume percent, which is considered a normal value. So different things to think about. What might increase the usage? So that's going to be represented or reflected by a lower number. Okay, so you've increased the usage. So again, it would be reflected by a lower difference of the Ca minus the CbO2. And things that increase usage would be things that we're probably going to answer, hopefully correctly, of increasing oxygen consumption. So fever, exercise, seizures, shivering, and low cardiac output. What about the flip side? What is going to decrease the usage, which would result in a higher number? So anything that's going to slow your metabolism. Okay, things like hypothermia, peripheral shunting, and certain poisons. All right, so oxygen consumption. Oxygen consumption is the amount of oxygen used in 1 minute time. Okay, so when we look at oxygen consumption, so for example, if we are, for this calculation, again we're looking at cardiac output, and then we're looking at the difference at Ca minus CbO2, again times 10. So for example, if we're giving numbers such as 5 for our cardiac output and then 5 for our A to B difference, and we do the math, we should come up with 250 mils of oxygen per minute. So 250 mils of oxygen eaten up by the tissues. And a normal value is about 250 to 330 of mils of oxygen per minute. And that can vary with body surface area. So things that increase oxygen consumption, which we already talked about before, are things that would increase anything in metabolism. Okay, so increase oxygen consumption, which is going to be represented by a decrease in the number number are anything that was increasing metabolism. Okay, so we look at exercise again, fever, shivering. Things that are going to decrease your oxygen consumption would be skeletal muscle relaxation, again peripheral shunting, hypothermia, and poisons. Okay, so now we're looking at the amount of oxygen, the oxygen extraction ratio. Okay, so this is basically looking at the amount used compared to what is started with, so the ratio between that. So in order to calculate that, we have to take the CaO2 minus the CvO2, get that value and divide it by the CaO2. So for example, if we're working with the numbers of 20 and 15, we would basically take 5 then, because we have the 20 minus the 15 equals to 5 divided by 20. It's going to be 0.25 times 100, then is going to be 25%, which normal is about 25% because we're working with normal values, which means under normal circumstances at patients' hemoglobin returns to the villi is about 75% saturated with oxygen. Okay. So things that are going to increase that extraction ratio, which means an increase again in the number, is going to be things that increase your metabolism, also anemia, things that are going to decrease your extraction ratio, which is going to be reflected in a decrease in the number, are going to be things like decreased metabolism, high hemoglobin, and high PaO2. So again, remembering that a normal is 25%, which means under normal circumstances, a patient's hemoglobin returns to the villi about 75% saturated with oxygen. I want to make sure here I'm not forgetting anything. So that's your SvO2 sat basically when you're saying that. So your SvO2 should be 75%. All right. Now looking at mixed venous oxygen saturation. The true number of this would be taken from a pulmonary artery catheter, from a swan, where you'd actually get the true value. There are some calculations out there. Normal, again, like I mentioned, is 75%. It does say that 65% is acceptable. So things that are going to decrease that number are things that actually increase your your oxygen, O2 ER, on my little shorthand here. So things that decrease the SvO2 are going to be the same things that increase your oxygen extraction ratio. So those are things that I mentioned before, which would be a low cardiac output, high oxygen consumption, exercise, seizures, shivering, anything that's going to increase your metabolism, and hyperthermia. And then things that increase your SvO2 would be a high cardiac output, skeletal muscle relaxation, peripheral shunting, and poisons and hypothermia. All right, now we're going to talk a little bit about pulmonary shunting. If you look at Desjardins, this is where I got this from, page 280. Sorry, page 282. And this kind of is describing all the different types of shunts that we're going to be talking about. So for the first one, I'll be referring to the anatomic shunt, which is on picture B. Okay, so your anatomic shunt, basically look at that as kind of bypassing. Okay, there's no gas exchange going on. Blood flow from right to left with no contact from the alveoli, no contact with the alveoli. So things that can cause that can be congenital heart disease, septal defects, intrapulmonary fistula, vascular tumors. We also have the bronchial venous drainage, that azygos, hemazygos, and the intercostal veins. That makes up only about 1%. And then the Bayesian veins, venous, that's about 2 to 3%. I also got some notes from this on page 185 out of Egan's, but the picture kind of helps. So this is a true shunt, where it just kind of bypasses it. And then an absolute, this would be more on picture C, okay? You're looking at the capillary shunt then, that's what they're referring to. This is where you're going to have perfusion, but no ventilation, okay? I know sometimes it's kind of confusing the way they word this, but go with Desjardins as far as anatomic shunt and capillary shunt, okay? So this is where you're looking at alveolar defects. So you're having perfusion but no ventilation. So you have to think of some of the main causes then of this is going to be atelectasis, alveolar fluid accumulation, and alveolar consolidation. So these shunts are refractory to oxygen, so they do not respond to oxygen. Okay. So how do we treat these? We need to consider suctioning, possibly a bronch, PEEP, diuretics, and mucolytics. Okay. So the collapsed alveoli are too far away from the blood vessels to properly participate in gas exchange. That's kind of what we're seeing. They do not respond to oxygen because the alveoli are unable to accommodate any form of ventilation because there is no ventilation, therefore no gas exchange. The blood that bypasses any functional alveoli are already fully saturated except for a very small amount that are dissolved in the plasma, at 0.003. Okay, so I have in my notes that the sum of the anatomic, which I mentioned in the previous slide, and this capillary, those two added together is really your true shunt. Alright, then we have shunt-like effects. Okay, so we have more perfusion than ventilation. So these are kind of like our relative shunts. And this would be represented by D as a dog on your Desjardins page 282. So we have more perfusion than ventilation, so our treatment would be to give more oxygen. Perfusion is in excess of ventilation. Your breathing cannot keep up with the oxygen moving through the alveoli. So you can still treat with oxygen because some of it is still getting through. So what can cause this? Hypoventilation, such as COPD, bronchitis, asthma. This is where you're going to have more of a ventilation-perfusion mismatch with your bronchospasm associated with asthma, mucus accumulation associated with bronchitis, COPD, and alveolar capillary defects such as alveolar fibrosis and edema. Alright, looking at the shunt equation, how we calculate this out. So this is basically the cardiac shunt. Your QS is your cardiac shunt divided by your CO, which is your total cardiac output. So the QS then is the cardiac output that is shunted, is kind of what you're looking at, divided by your total cardiac output. And this is how you would get it, looking at your CCO2 as your oxygen content of your capillary blood. So the things this is part of your homework. I do ask, I think the specifics are on your homework as to how much. I want you to do at least 2 problems where you're doing all the math, long-handed, and then the other ones you have to plug in your numbers properly in your calculations, but you can actually do your calculations with your calculator. But make sure you have the right numbers that you're working with, because people still make errors. So I know this is part of your homework, is to figure these out. So the things that you're going to need to figure out these calculations are going to be your barometric pressure. So unless it's otherwise stated, just use 747. Okay, so 747, unless it's given a different number. So as we look at the next slide, this one here, they want you to calculate your shunt. So what is the percent shunt? So what we should be looking at here is you're taking your CCO2 minus your CaO2, so you're going to have to do all the math to figure out those, and then divided by your CCO2 minus your CbO2. So again, all the math that's associated with to figure out those values. So remember, your CaO2 is going to be your 1.34 times 13 times 0.85 in parentheses plus 50 times 0.003. So you should be getting for your CaO2 14.96 volume percent. And then for your CbO2, you should be using your all your Venus numbers, which should give you 11.43%. And so to figure out then your CCO2, you're going to have to take your hemoglobin times your 1.34. Then you have to figure out your PaO2, so your velar air equation. And that's where you're going to use 747 to figure out your PaO2, your big PaO2. And you should get 18.73 for your CCO2, for your capillary O2. Then you are going to do all your math, and you should get a percent shunt of 52%. Is this bad? Yes, it is very bad. You should be getting less than 30%. Anything greater than 30% is bad. Okay, so moving on to the next. So normal really should be less than 5. Like I said, greater than 30, you're looking at life-threatening, aggressive cardiopulmonary support. Does the patient need blood? Do they need improved blood pressure? Is there some type of diffusion defect going on? Fibrosis? So a normal shunt would be considered less than 5, though it does say 10 to 20 abnormal, but clinically insignificant. Interesting. Okay. Now we're looking at the 4 different types of hypoxia, tissue hypoxia. Okay, we have hypoxic hypoxia, anemic hypoxia, circulatory hypoxia, and histotoxic hypoxia. So for some reason there's not enough oxygen for cellular metabolism. Right, hypoxic hypoxia is an inadequate oxygen at tissues caused by a low PaO2. So this can be caused by pulmonary shunting. It can also be caused from hypoventilation, so COPD patient, an overdose patient, neuromuscular disease, or high altitudes. The other thing we need to look at is diffusion impairment. So this would be time for oxygen. The diffusion is inadequate. These could be indicated by interstitial fibrosis, could be a cause, alveolar consolidation, interstitial or alveolar edema. Okay, so we need to consider that. Or is there a VQ mismatch? So do we have a perfusion in excess of ventilation? So those are things to consider, or reasons for. Our PaO2 is normal here in anemic hypoxia, but the oxygen oxygen carrying capacity of the hemoglobin is inadequate. So there's not enough hemoglobin to carry the oxygen. So low hemoglobin, deficiency in the hemoglobin ability to carry O2. Other causes can actually be carbon monoxide poisoning. We could have a decreased hemoglobin concentration due to, again, anemia or possibly hemorrhage. Abnormal hemoglobin would be from carboxyhemoglobin or methemoglobin. So something to keep in mind when you're doing nitric. Circulatory, so now we need to look at why are we not getting the oxygen out there. So the circulation isn't adequate to transport. We do not have enough flow. So blood flow to the tissues is inadequate. Could be caused from stagnant hypoxia. The flow is slow, so it's stagnant or pooling. There could be AV shunting going on. Blood completely bypasses the tissue cells and moves into the venous system. Some of the causes can be hypovolemia. That is commonly associated with decreased SvO2. And again, Desjardins can kind of help you with this. Histotoxic hypoxia happens in any condition that impairs the ability of tissue cells to utilize oxygen. So clinically, the PaO2 and the CaO2 in the blood are normal, but the tissues are extremely hypoxic. So your PvO2 and your CvO2 and your SvO2 are elevated because oxygen basically isn't being used. And one cause of that is cyanide poisoning. Okay, make sure you do your homework that's associated with this, all your calculations, and I will see you next time.